Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce session 23, Navigating the Post-COVID World Through Data Science. It will be presented by Imran Qureshi, Chief Data Science Officer, Clarify Health. Enjoy the session.
Thanks, Stu. Before we begin, let me ask you a couple of questions. You don't have to give me the answer right now, just think about it and we'll come back to it in the middle of the presentation. The first question is, does 2020 or 2021 look anything like the years before? The second question is, what is the most fundamental assumption of machine learning? So let's jump in and we'll come to those in a bit. So we've been working with a number of providers and payers around the country, and we found a few months ago, a number of them came to us with pretty much exactly the same question. The question kind of went like this. It said, since March, we have a number of patients that can't see their PCP, can't come to the hospital, maybe they've lost their job and don't have health insurance anymore. So we would expect that some of those people are going to have some adverse outcomes as a result of these care disruptions. So how do we identify which of those people we should focus on? Which are the ones that are going to have the biggest impact as a result of this care disruption? And which of the care disruptions should we try to address with each patient? So this is the question that I'm going to start with in this presentation. What we're going to cover is kind of a summary of the problem, right? And talk about why it's important to payers and providers. Then I'm going to put up a really simple chart I've drawn that explains the care disruption a little bit. We'll talk about the fundamental question, how to identify patients who have the most increased risk due to the care disruption that they're suffering right now, and how to identify which care disruption to address. Then we'll change gears a little bit. I'm going to throw a wrench in the works a little bit and talk about why our current method of evaluating physician performance is going to be problematic in 2020. And lastly, we'll talk about how to accurately predict risk and utilization for 2021 when we don't think 2021 is going to look anything like any of the past years. So let's jump in. So care disruptions. You guys have probably seen this already. The number of people going to ambulatory practices declined in early April by about 60%. As things started to open up, it came back up, but it's still about a third of what it was before. In the meantime, the percentage of telehealth visits has increased. Before COVID-19, it was about 1%, right? Nowadays, it went up all the way to, I think, 14, 15%, and now it's like roughly 12%. Diagnostic testing is down. A lot of people are not doing that anymore. And then also just in terms of the number of people coming into the hospital, it's down by about half just because people don't feel safe coming in or hospitals have told people not to come in. When you look at ER visits, you kind of see the same chart really. When you compare it to 2019 at the top, you can see there's a big dip around the mid-March, early April, and then it's started to recover, but it's not back to what it was before. Medication refills is frankly a very interesting one. I think this is, I got this wrong myself. I assumed that medication refills rates would actually go down, but actually the opposite has happened. And I think it's kind of understandable. You think about people are afraid that they won't be able to get medications anymore, so they're refilling them ahead of time. Or they may be trying to remain healthier, so they reduce their risk of contracting COVID-19. However, there is a big disparity here we see, where high-risk patients are actually refilling their medications at about the same rate, but people who are at low risk are actually refilling their medications early. When you look at medication adherence, for example, for asthma, you kind of see that it's actually gone up too. And I would suspect it's because people are trying to remain healthy to reduce their chances of getting COVID. On the sad side, a lot of people have lost jobs as a result of COVID-19, and that has caused an increase in the uninsured population. So a much higher percentage of the country is now uninsured. During this whole backdrop of care disruption, hospital revenues are quite a bit down too. This is driven by many factors, one of which is that the reduction in elective procedures they're able to do, which are quite low. The other good news, I guess, is that not every care disruption has had a bad effect. Right? If you're generally healthy and you don't go see your PCP, probably you're going to be fine. There's probably not going to be much more impact on you. On the other hand, if you have serious conditions that require a lot of maintenance and you don't go see your doctor, or you don't fill your medication on time, or you are become uninsured, then you're going to likely to see adverse outcomes in the coming months. But that's why you need a data science model to be able to say, these are the patients that are going to have the most impact as a result of care disruption. So you should focus on this small set of patients. Okay. So let's bring up my simple chart, right? This is not going to win any awards, but here's how I kind of think about this. So you did a period, what I call pre-COVID-19 period, right? This goes on for a number of years. Things go, if you look at any measure like PCP visits per month, it kind of goes up and down, but generally kind of is stable year over year. Then the COVID-19 disruption period happened, and you can see all the curves kind of drop down. And there's two sets of patients, right, that are addressed. The first set, of course, are people who contracted COVID-19. So that's acute disruption. They had to be hospitalized and taken care of. But there's a much larger set of patients that did not contract COVID-19, but had their care disrupted. They couldn't go see their PCP because the PCP office was closed, or maybe they were afraid to go see the PCP. And so they're skipping PCP visits. They may not be vaccinated. All of those stuff happen. As things start to open up, right, you're starting to get into this third period called return to normal. I put normal in quotes because there's uncertainty about what the new normal will be. Right? So there's two things we're really uncertain about in this period. The first one is, how long will it take to return to a normal? The other question is, what will the new normal look like? So I've kind of drawn three lines here. You can see the green line is sort of assuming that things get back to the previous normal very quickly and everything's what it was before. The orange line suggests that it takes a long time to get back to the normal, but the normal will be what it was in the past. And the red line indicates that maybe we never get back to the normal. Maybe the number of telehealth visits never drops back down to 1%. Maybe the number of PCP visits is always going to be lower now. We do not know. And so that is a fundamental problem we have, that the future is very uncertain now. So we'll talk about how we can still use data science to be able to make good decisions about the future when the future is so uncertain. Okay, so let's jump into kind of the question that our customers posed us, which was, how do you identify patients at most risk for adverse outcome? So there's many different types of care disruption, but let's just focus on a few to keep it simple. So there's the switch from in-person to telehealth visits we talked about. There's sort of the reduction in various types of visits like ER visits, PCP visits, diagnostic testing, routine screenings, routine stuff. There's also the prescription refill rate changes. There's medication adherence, and there's also the change in the uninsured population. So here's the slide that's probably the most important in the whole deck. So if you're going to pay attention on one slide, this is the slide you should pay attention on. So the big problem is, when you think about this, is how can we predict the impact of COVID-19 disruption? Because COVID-19 has never happened before, right? And so we don't have 2 years of data past COVID-19 to understand what is the impact of that to various outcomes. That's certainly true. However, care disruption has happened in the past. Right? People have stopped seeing their doctor or reduced their PCP visits because they lost their job, because they got busy, because the doctor retired. Various causes have resulted in care disruption in the past. Now, certainly that hasn't happened to the same number of patients, of course, right, as COVID-19, but it has happened to a small percentage of patients. So what does that mean? That means that we need a large enough data set so we can find enough of those patients where there's care disruption that we can train models on. So assuming you can find that, then how do we actually deal with it? So one of the ways you can deal with it is you can include care disruption as a feature to your models. So let's take an example here. So there's 3 patients, and we included a new column. Right? They have the standard columns of age, gender, diagnoses, and we added a new column that said whether they had a PCP visit disruption or not. And then we still have whatever outcome we care about. It could be cost, it could be mortality, it could be inpatient days, whatever we're trying to model. So now if you train a model, again, on past data, when care disruptions happened, the model will learn that there's an impact of having a care disruption on the outcome. So think about that for a little bit. Okay. So hopefully that makes sense. As a result, the model can start to predict what is going to be the impact in the future of those care disruptions. One of the questions that I was asked when I first talked about this was, well, these care disruptions are being caused by COVID-19. What about that? We've never had care disruptions because of COVID-19 before. That's true, but you can think of it as 2 impacts that you add together. There's an impact of the care disruption itself, right? Not seeing the PCP visit. And then there's an impact that's due to the cause of you not seeing the doctor. And the total impact is, of course, you add those 2 together. But frankly, we do not have data, as I mentioned before, on the second one. We do not know what the impact of the cause of COVID-19 is to outcomes. So we can just focus on the first part, and that still helps us figure out which are the patients we should focus on. The second thing, as I talked about, is you're not going to find a lot of these care disruptions in the past, certainly not at the scale that we see with COVID-19 today. So you can use data science techniques to account for that. For example, class balancing, oversampling, and zero inflation are various techniques you can use to handle the fact that you have fewer positive samples in the past than you do today. Let's talk about how do you quantify care disruption, right? We talked about it as a concept. It's kind of makes sense as a concept, but we want a number, right? We're going to feed something into a model as a feature, we need a number. So how do we calculate that? So first is to quantify the care disruption. You could do it many different ways, right? The way we chose to do it is this way. It doesn't mean this is the only way you can do it. For telehealth visits, we calculated the proportion of telehealth visits to normal visits. For ER visits and PCP visits and specialist visits, we calculated the visits per month. For prescription refills, we looked at the proportion of late refills to total refills. And for the uninsured population, we looked at the number of uninsured months. You could certainly also choose number of insured months. It's kind of the flip side of the same thing. So that's how you can start to quantify it. So then the question is, how do you calculate a number? How do you calculate a number that says this is how much care disruptions actually happen? And to take into account, there's going to be noise, right? Someone, instead of going to see the doctor on June 29th, goes to see the doctor on July 1st. So that means that visit counts under July instead of June. So there's going to be some noise there. So how do you account for that? So there are many ways you can do that. There's certainly a more complex time series analysis that we do. But the simplest way to think about that is a change in moving average. So if you think about a 3-month moving average, it will tend to dampen out the noise, because if someone went in June rather than July, it doesn't really matter because you're looking at the average in the 3 months. And then as you move that moving average around, you'll see when that actually changes. So in this case, you can see for the first 3 months, the patient was seeing the doctor 4 times a month. Right? So their moving average is a 4. And then something happened. And now they're seeing the doctor 1 time a month. So you can say that there's a difference in the moving average from 4 to 1, and that can be used to quantify that care disruption. So now that you have a calculation, right? So now you can use that moving average calculation to calculate a care disruption, how do you now feed that into your model? So there's two ways you could do that. One is you could feed it in just as a binary feature. You could say whether care disruption happened or whether it did not happen. That's simple, and you can do that. What you can also do is pass it in as a continuous feature, in which case you're saying not just whether it happened, but also what is the level of it happening. So for example, if one patient used to see the doctor 4 times a month and is now seeing him 1 time a month, compared to another patient who used to see the doctor 4 times a month and is now seeing them 3 times a month. They both have care disruption, but the value of care disruption is different. So let's walk through this example a little bit more detail. So you can see the first patient you're looking at. So they decreased their visits from 4 to 1. As a result, they have a PCP visit care disruption of -3. Now again, like I said, there are many ways to calculate that. This is the simplest way. If you look at the insurance disruption, last year they were insured for 12 months out of the year. This year they ended up only being enrolled for 8 months out of the year. As a result, they have a -4 disruption to their insured status. So this is how you can construct these features. And then you include them along with case mix features in your model, and you train it against the same outcomes that you're training with today. These could be total costs, these could be mortality rate, inpatient days, admissions, whatever you look at. So what will happen if you do that? What will happen is the model will learn what is the relationship of this visit disruption to the outcome. And each disruption will be another feature that it will put a contribution on. Now, this can also go in the other direction, where the third patient, you can see, they start seeing the doctor more often. So they actually have a plus disruption because they actually used to see the doctor maybe 5 times a month, and now they're seeing him 6 times a month. So the model also learns what happens when the disruption goes in the opposite direction. Okay. So that was good. That's a pretty good explanation for probably data scientists. So now we're going to simplify it even more. Right? Let's think about it as how we would explain it to a 5-year-old or my kids. So this is going to be highly oversimplified. So let's say there are 2 patients, Jim and Bill. Right? Jim, let's say they're exactly the same kind of patient. So they both have the same cost. But in 2017, we see that Jim's cost went to $30,000 and then stayed steady. We then look at their PCP visit disruption feature that we created. You can see that in 2016, Jim experienced a PCP visit disruption of -3. So, they went from 4 to 1 PCP visits a month. So if we just create a model just on this, what the model will learn is that when the PCP visit disruption of -3 occurs, then the costs go up by $10,000. So this is, again, in the past, has nothing to do with COVID-19. That's how we can train the model. Now we can pick up the same model and then bring it over to now. And we can look at a patient, Mike, who's having care disruption due to COVID-19 right now. And we can predict on Mike. And let's say Mike has the same visit disruption. He also went from 4 visits a month to 1 visit a month. So the model will now predict that Mike's costs should go up by $10,000 next year. Again, in reality, you don't need patients that are exactly the same. The data science models can handle them being different, and you don't need the visit disruption to be exactly the same. But this gives you a really simple way to understand why this technique works. A key thing here to think about is that you always have to combine case mix with care disruption. So for example, if you have 2 patients, Jim and Jane, and they both had the same reduction in PCP visits, but Jim had many conditions and Jane is healthy, then you would expect that Jim would have a much more impact of that care disruption than Jane. So by including case mix and care disruption together, your model will be able to adjust for that. Okay, so that didn't fully answer the question, right? That answers the question of, okay, we can predict what the risk or utilization of someone will be in the future. how do we identify the patients that are at highest increased risk due to care disruption? So let's take this example. Let's say we train two models. We trained a model without using care disruptions as features. That's the first one you're looking at. In that, Jim and Bill are exactly the same. They have the same feature value. Now their actual costs are different. Jim is 100,000 and Bill is 60,000. So the model has to predict the exact same amount for both of them because their features are exactly the same. So what the model will do is we'll try to find the average of the two and we'll predict $80,000 for each one of those. Now let's say we trained a model with using care disruptions as features. So now there's a difference in features between Jim and Bill. So the model can now separate them and can actually predict a more accurate value for both of them. So in this case, it predicts 100,000 for Jim and 60,000 for Bill. Now, of course, in reality, it's not going to be exact, but we're simplifying there. So this is what will happen if you train two models. So how can we use this to answer the question we're really asking? Which is we want to calculate the increase in risk due to care disruption. So if you take the prediction that we had for Jim, $80,000 to the first model, and then you take the prediction we have for Jim to the second model that includes care disruptions, you get a total cost of you get $100,000 in second. If you subtract the two, you get $20,000. So essentially, the risk of Jim is increasing by $20,000, which can be largely attributed to care disruption. So now you can look at this difference between the two models, and you could rank patients by the amount of difference they have, because that will be the amount of risk there is increasing due to care disruption. So the last part of this question is, out of all the care disruptions that are happening, patients aren't seeing their PCP, they may be losing insurance, which is the one that we should address for each patient? So again, we got Jim at the top. You guys saw this before. What we can do is we can use something called a feature contribution. A feature contribution is a concept in data science that takes your prediction and then distributes that prediction to each feature. So you can understand how much is each feature contributing to your prediction. So for example, in this case, it says that age is contributing $40,000 to the total prediction of $100,000. And then gender subtracts 5,000, PCP visit disruption adds 30,000, and then insurance disruption adds another 5,000. So looking at the feature contribution, it becomes pretty obvious that for this particular patient, we should address their PCP visit disruption first, because that is contributing the most to the outcome we're interested in. Feature contributions are a very important element in machine learning. There's lots of libraries available for that, including SHAP or LIME. But if you're dealing with large amounts of data, like 10 million patients or above, we've also made an open source library available that can calculate feature contributions for tens of millions. Okay, phew. We've answered that first question we had that lots of people asked us. Let's shift gears now and talk about some more problems that we should expect, right? We want to find out more problems that we have to deal with. So the second one is the problem of evaluating physician performance in 2020. And let's talk about why that would be a problem. But before we do that, let's just create an oversimplified version again of how in the industry we tend to evaluate physician performance. The way this works is, let's simplify. Let's say Dr. Jones has two patients that are exactly the same, again, Jim and Bill. And so their cost is 110 and 90. So we would say the average cost for patients like this for Dr. Jones is $100,000. Now we find the same patients that are being treated by other doctors. Tim, Chad, and Joe, let's say, are other patients that some other doctors are treating. We look at their costs, and their average is $60,000. So we would say that Dr. Jones is not doing a very good job in controlling costs, because the same patients, when they go to another doctor, they tend to have much lower total costs. So this is how, in an oversimplified way of how physician performance is really done. Again, in reality, the patients don't have to exactly match. The data science models can handle that. This is also called risk adjustment or case mix adjustment. So what is the problem with this? Well, let's add one column in and see what happens. So let's add in the column of when that patient's episode started. So let's say for Jim and Bill, their episode started in January. And in January, the world was different. The care patterns were different. People could go to the hospital when they wanted People could go to ER if they wanted it. People could go to physical therapy when they wanted it. All that stuff was available. And so as a result, you would expect that patients would incur higher costs because they would go to the physical therapist, they would go to the hospital if they need it, or they may spend more days in the hospital. Now you look at the patients that the other doctor is treating, and you can see their episode happened in July. In July, when people had a hard time going to hospital, probably most people were skipping their physical therapy. And so as a result, the costs of these patients are actually lower. So now, can you really say that Dr. Jones is a bad doctor? And so this is the fundamental problem with comparing physician performance in 2020. We have to be able to account for this if we want to fairly calculate physician performance. This is not a problem in past years because whether you went to the doctor in January or you went to the doctor in July, the care pattern was very similar. So you did not have this problem. So how do we account for this? So let's look at two of the more common analyses we tend to do. So the first one is episodic analysis, where we look at seeing when a patient has an episode, let's say they went in for knee surgery or they went in for heart valve replacement, what happens to them 90 days after, 180 days after? So we're going to evaluate physicians based on how well patients do for the same episode. So we saw what the problem was before. So the way you can address that is you can split your data into episodes that happened pre-COVID-19 and the episodes that happened post-COVID-19. And you can train a separate model on that. The reason for training a separate model is because the care patterns are completely different. So it's going to be extremely hard for one model to be able to understand the differences. Why did this patient cost $100,000 in January, but the same exact patient cost $60,000 in July? And then when you're evaluating the physician, you can choose the appropriate method based on the episode you're looking at, create a prediction, and then you can average those predictions to get what the doctor's valuation. The other kind of analysis we tend to do is what's called time-based analysis, which is you look at how does the PCP do in 2016 or 2017. So you can do a very similar technique where you can split the year in two. You can have a period between January 1st and March 13th, and then a period between March 14th and the rest of the year. And then you can divide up the patient's year into those, use a separate model for each part, and then add them up to get the prediction for the whole year that you're going to evaluate the patient on, or the doctor on. Again, when you're dealing with things like probabilities, you don't really add them. There's a more complicated math, and we'll keep it simple for now. Great, so we talked about how to identify people at increased risk due to the care disruption. We talked about how to fairly evaluate physicians. So congratulations, you got to the last stage. And we're going to talk about how to accurately predict risk and utilization in 2020. So what is the problem? And so let's go back to the question I asked at the beginning of the presentation. What is the most fundamental assumption in machine learning? Hopefully you guys got a chance to think about it. The most fundamental assumption in machine learning is that the future looks very much like the past. That's why we can train models on data in the past, and we can use those to predict the future. The first question I asked in the presentation was, do we think 2020 and 2021 will look anything like the past? If you're like most people, and like me, frankly, you probably said no. So that creates a big conundrum. How do we accurately predict 2021 now when 2021 is not expected to look anything like any of the years in the past? So let's again break it down by, we got time-based analysis and episodic analysis. So there's two things, at least two ways you can adjust for that. One we talked about already, which is using care disruptions as features. Because care disruptions have happened a lot in 2020, you have to include them if you're going to be accurate in predicting what's going to happen in 2021. The second thing is, remember back to my silly drawing? We said there's two things we don't know about the future. One is how long will it take to stabilize to a normal? The other thing we don't know is what will that new normal look like? And frankly, there's just no way to predict that because there's so many variables in our society right now for us to be able to predict that. When will the vaccine come? How effective will it be? How will we manufacture it? How many people will actually take the vaccine? how many people wear face masks, how many people do social distancing. So you can use a technique called what-if modeling to be able to handle that. So let's talk about that. We've seen this slide before, so I'll be pretty quick on it. You saw that the model without care disruptions was not very accurate because it had no additional information to understand why Jim would cost more than Bill. By adding care disruptions as features, now you can get a much more accurate prediction because the model can figure out why Jim and Bill, who look the same in case mix, are actually have very different costs. All right, so the what-if modeling is maybe the new part, right? So let's think about a question that the health system might have, which is how many ER beds should I plan for in 2021? Should I increase the number of ER beds I have, or should I decrease them? So it's very hard for us to get the answer to that, but we can do a what-if modeling exercise. We can allow them to model what if 10% of the people only came back to their normal PCP visit patterns? What would happen then? How many ER beds would you need? Or on the other hand, what if 90% of the people came back to the normal PCP visit numbers? Then how many beds would you need? So by looking at these two predictions, you can get a sense of what is your worst case scenario and your best case scenario. And you can again do more of these to get your most likely case scenario. And then be able to plan for it, saying, okay, we're gonna need more beds in the worst case scenario, but not more than the best case scenario, or vice versa, however you want. When we did that, what we discovered was, frankly, there's an infinite combination of these scenarios. What about if the PCP visits stay reduced, if more telehealth visits happen, if the ER visits stay down, if medication adherence goes up, what would happen? So we ended up giving our customers a UI where they could explore these scenarios. They could try out various expectations that they had and see the impact of those expectations on future outcomes like cost, mortality, ER beds, inpatient days, admissions, all of that. Phew, we covered a whole lot. Hopefully people are probably tired by now, but let's just summarize our key learnings. So one is that care disruptions are going to have an impact on future outcomes for the people who don't even have COVID-19 but have had their care disrupted. It's true that in the past, we've never had COVID-19, but there have been care disruptions in the past for other reasons. So we can extract those and train models that understand the impact of those care disruptions to any outcome we're modeling. And the last point is that the future is much less predictable now than it was 6 months ago. So the way we can deal with that is use what-if modeling and allow predictions on a range of scenarios. And then that provides insights to providers and payers to be able to make better decisions about the future. So thank you for your time. It was a lot of stuff we covered. Happy to answer any questions you guys have in the question section.